Every year, the medical research enterprise generates a massive volume of highly efficacious nursing interventions. We have thousands of proven protocols designed to improve clinical outcomes, yet the vast majority of this knowledge remains trapped on academic bookshelves, completely inaccessible to the patients who actually need it. When we look at the data, the scale of this bottleneck is staggering. Overall, only 1/3 of strong, validated clinical evidence is ever systematically implemented into routine healthcare practice. Even when interventions survive, reaching clinical sustainability takes an average of 17 years. This sluggish pipeline also causes a failure of de-implementation. Because evidence takes decades to penetrate the system, actively harmful practices continue circulating in patient care long past their expiration date. This massive gap between evidence and the clinic is not a failure of individual nursing skill or dedication. It is a catastrophic systems engineering failure that squanders billions in research efforts and degrades the quality of cutting-edge clinical care. Traditionally, the medical pipeline treats publication as the finish line. There is a deeply flawed assumption that once a clinical trial's results are printed in a major academic journal, those findings will automatically translate into real-world practice. To repair this pipeline, the nursing profession must adopt a rigorous structural framework known as implementation science. Implementation science is defined as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. It is the dedicated science of ensuring that proven ideas actually survive in the real world. Fixing the translational pipeline requires 3 distinct pillars working in unison. First, methodological rigor provided by implementation science. Second, tapeable deployment vectors on the ground, specifically advanced practice registered nurses. And third, effective patient interfaces, managed through nursing informatics. In modern healthcare, evidence-based nursing cannot exist without evidence-based implementation. Traditional randomized clinical trials operate in sterile, highly controlled environments. They rely on strict inclusion and exclusion criteria to isolate specific variables. But community health clinics are chaotic, multivariable environments where those strict controls immediately collapse. This friction is why researchers utilize comparative effectiveness research, or CER. CER is a methodological framework that compares one or more evidence-based treatments head-to-head in real-world settings, without the strict participant filters of a traditional trial. In the United States, comparative effectiveness research gained major systemic infrastructure as a component of the 2010 Patient Protection and Affordable Care Act. The ACA established the Patient-Centered Outcomes Research Institute, a funding agency specifically dedicated to advancing this exact type of real-world research. While traditional trials focus purely on efficacy, asking simply, can this treatment work in a lab? CER and implementation science focus on true effectiveness. They mandate tracking specific implementation outcomes like fidelity, reach, and adoption to answer the much harder question, does this treatment work here for these specific patients? Measured pace. Interventions that succeed brilliantly in a highly controlled clinical trial will consistently fail when dropped into a community setting unless they are rigorously reevaluated and adapted through a comparative effectiveness framework. To execute this kind of systemic change across a fractured healthcare landscape, you need highly specialized agents on the ground. This role falls to Advanced Practice Registered Nurses, or APRNs. APRNs are licensed independent practitioners, a classification that includes nurse practitioners and clinical nurse specialists. Because they increasingly fill the void in primary care caused by physician shortages, and their training focuses heavily on evidence-based care, they are the ideal deployment vectors for translating research into community practice. However, a critical deficit exists. Standard formal nursing education does not currently equip APRNs with the specific implementation science methods needed to independently execute comparative effectiveness research. Building that capability requires a multi-stakeholder advisory team model. By combining the on-the-ground experience of APRNs, the financial and regulatory perspectives of organization leaders, and the lived experiences of patients, systems engineers can build a responsive, highly targeted implementation training curriculum. Clinical change survives when ground-level practitioners are explicitly trained in implementation strategies and supported by cross-functional stakeholders. Once an APRN understands the research, they must physically integrate it into a clinic. This means targeting entrenched friction points and overcoming specific barriers at the system, provider, and patient levels. Before deploying any new protocol, practitioners must perform a contextual analysis. They have to rigorously assess an organization's actual readiness for change, evaluating whether a particular intervention is a practical and financial fit for their specific environment. This process requires precision. The APRN modifies the intervention to fit the local clinic's workflow, while strictly maintaining the original research design to ensure the treatment remains effective. To manage this complexity, practitioners need robust post-training support. Organizations must provide physical and digital implementation toolkits, resource guides that offer ongoing technical assistance with project design, database management, and data analysis. Providing clinical knowledge without simultaneously providing an ongoing, structured implementation toolkit guarantees the failure and rapid unsustainability of the intervention. Even with a perfectly trained APRN and a robust clinic, the entire system faces one final choke point at the moment of patient contact. In modern healthcare, this final mile is heavily dictated by technology, introducing the looming threat of the digital divide. This prisma diagram shows how thousands of initial records are filtered down to a final set of studies mapping how older adults use healthcare technology. The discipline managing this intersection is Nursing Informatics, integrating nursing data and communication technologies to promote holistic patient care. To operationalize this science, researchers have characterized Nursing Informatics into 4 distinct modules: recognizing nursing informatics as a specialized profession, defining the exact competencies required of nurses, developing standardized assessments, and promoting eHealth literacy. If a patient cannot interface with the digital delivery mechanism of an intervention, the entire 17-year research pipeline is rendered utterly useless in the final inch. Older adults represent the most vulnerable demographic regarding this digital divide. They are greatly underrepresented in the use of digital technology and frequently face difficulties accessing information, which inadvertently excludes them from vital eHealth interventions. The Nursing Informatics framework expands the clinician's role. Nurses act as educators and mediators who translate technical systems into accessible patient care. Their primary goal is building the patient's eHealth literacy. eHealth literacy is a patient's ability to seek, find, understand, and appraise health information from electronic sources, applying that knowledge to solve a health problem. High eHealth literacy directly correlates with highly successful disease self-management. Practitioners cannot simply assume technological competence. They must quantify these skills using validated clinical assessments, like the eHeal scale to measure a patient's digital literacy, or the TANIC assessment, which evaluates the MRSA's own informatics competencies. Treating technological literacy as a measurable, critical clinical vital sign is the only way to guarantee equitable access to modern, evidence-based care. A functioning medical pipeline requires continuous flow. An idea must move efficiently from the rigorously tested literature of implementation science into the hands of an APRN equipped with a targeted toolkit, across the nursing informatics interface, and finally into the patient's daily life. Clinical diagnostic knowledge alone is no longer sufficient. The modern nurse must possess methodological rigor to evaluate evidence, leadership strategy to navigate clinic workflows, and technological advocacy to bridge the digital divide. By adopting this multidisciplinary, systems-engineered framework, the nursing profession can finally collapse that 17-year delay, translating laboratory bench science into sustainable, real-world healing.